Okay, these are, can you hear me? Yeah. These are my disclosures here, and basically in the last two talks, we've heard very promising kind of information about a new field. We think we've learned a lot about cervical deformity in the last 5 years. Certainly, though, we have a lot to catch up relative to what we know about adult spinal deformity. And some of the results, kind of the emphasis of this talk and the continuation into the afternoon talk is that a lot of our results initially with the treatment of adult cervical deformity is very humbling. And, our group started the kind of one of its kind, a large database of adult cervical deformities and self-professed experts in treatment of spinal deformities, and the outcomes have been very humbling. Let's start off with a case example. This is a 63-year-old female patient, a history of osteoporosis, a seizure disorder, basically progressively becoming paraplegic. Clear, obvious coronal and sagittal cervical deformity. And essentially, this patient had a relatively uncomplicated anterior-posterior cervical procedure with a corpectomy as the main correction generator in the front. And this patient initially had a great outcome on initial treatment. Due to their history, they were discharged on Forteo, as well as protected for 3 months with a correction 2 months for in the CTLSO. And initially had a really good outcome, very happy with the results, 3 months ecstatic. Unfortunately, the clinical results here, and a lot of this is really in part due to the patient's risk factors, really fell apart very quickly. This was one of the initial large deformities that I treated, but clearly we didn't recognize the patient's global deformity as well as the risk factors that they had. So this patient presented approximately 7 months out from index procedure, and the patient presented with a Dens fracture, compression fracture below her construct. And you can see that the patient, you don't need to be an expert to see that this patient is high risk and frail. She has 2 kyphoplasties, a hip fracture, and she has a clear flat back deformity. So this patient was revised with extension of the fusion C1 essentially to the pelvis, trying to improve some of the lumbar generator of her symptom with an L4 PSO. The patient did well for a while. 20 months post-op, the patient is still having compression fractures in the thoracic spine with progressive kyphosis, despite being on Forteo, despite having essentially rebar with the instrumentation. So the patient underwent a VCR and ultimately did relatively well. She was starting off with a very frail state and a very low quality of life. Ultimately happy with her outcome, but certainly we have to think about, in a health-conscious environment, in a risk-averse kind of environment that we live in, we have to think about, are we operating on the right patients, and we have to think about them globally. So there's a lot of objectives to this talk. We're going to try to run through it expeditiously. You've already heard a lot of the concepts in the last 2 talks. But basically, one of the main issues here is that initially we're just looking at the cervical spine as a single entity, and that's really not the case. We have a lot of literature to prove that, as you've heard. Essentially, there's multiple causes of cervical deformity, but patients with adult spinal deformity in and of themselves are at risk for developing cervical deformity, with or without treatment. You saw the citation of Justin's paper, up to 53% incidence of cervical deformity among ASD patients, regardless of being treated. We know that this rate also goes up potentially with treatment of adult spinal deformities in the thoracolumbar spine. We published a 63% rate of cervical deformity at 2 years following optimal correction of their adult spinal deformity. Some of the risk factors were UIV above T5, and what you're starting with in the cervical spine is a baseline T1 slope minus cervical lordosis mismatch. And that's assuming things go right. So what happens when things go wrong? So we all know that PJK is a major problem in adult spinal deformities. We've seen in some of the morphology talks that patients tend to compensate for this by increasing their C2, T3 angle and their cervical lordosis up to a point where they're unable to do that depending on their muscle and physiologic reserve. And we found that global deformity and PJK angle were directly correlated with cervical deformity. This is a case example of a similar patient with a movement disorder, 61-year-old female patient with Parkinson's disease, extremely frail on our indices, which we'll talk about later. Patient underwent initially a routine posterior T4 to pelvis with the understanding that at some point they'll need their cervical spine treated. At a later date, they had a baseline cervical disease contributing to their symptomatology. Good initial clinical result. Within 2 years post-op, this patient has a chin-on-chest deformity. The patient underwent a T4 VCR, ultimately with a very good outcome. Did have a complication subsequent to that again, basically due to their frailty. There was hardware prominence, so we removed some of the screws at the apex of the thoracic kyphosis. But again, patient thankfully did okay. Another point that's worth noting is that, basically there's a subset. Overall, we're improving the results of our treatment of adult cervical deformities, but there's a subset of patients that we have to think about seriously of that have particularly poor outcomes and maybe potentially too high risk for surgery. So a lot of it's what we're starting out with. You heard it in Virginie's talk. Basically, it's patients with adult cervical deformities are not your typical patients and probably even more debilitated than patients with thoracolumbar deformities in and of themselves. So they're more frail, they have more comorbidities, they're more elderly, and their health-related functional quality of life scores are starting off at very minimal rates. And this translates into perioperative outcomes, something ourselves and our institutions are all highly concerned about in modern times. So one of the initial studies we wanted to do to kind of build on this concept towards the culmination of what we'll kind of hear about in the afternoon talk about a risk kind of benefit ratio of when to operate on these patients is to look at, let's just isolate patients that do not have a good outcome, and let's do an analysis of kind of what do these patients have in common, what are their risk factors. So we really wanted to identify patients who really had no clear benefit from their surgery, so had poor, and we defined this in multiple aspects. So that they wanted to have poor radiographic, poor clinical, and a lot of complications. And we wanted to isolate these populations so we know either we can optimize them prior to surgery or we can think about not treating them with such aggressive surgeries. So we used our prospective cervical database, as you heard about earlier. We defined a poor outcome in a threefold metric radiographically by deterioration or residual malalignment at 1 year in CSVA or T1 slope minus cervical lordosis. Clinically, we defined it as failing to meet clinically important difference in NDI or JOA at that same time point. And complications were defined as major complications, the occurrence of mortality, which is surprisingly high in our database, or the occurrence of a reoperation. And essentially, we used area under the curve analytics to come up with our models. And looking at the cohort as a whole, so just all of the slightly over 100 at this time adult cervical deformity that spinal deformity experts treated surgically. Radiographically, 73% of these cervical deformity patients had a severe T1 slope minus cervical lordosis, one of our major metrics we're trying to realign after surgery. Look at our clinical outcomes. 80% of cervical deformity patients failed to meet MCID for a very basic overall outcome measure, EQ5D, overall health status. 60% failed to meet MCID for NDI, and a quarter of them failed to meet JOA scores. Looking at our complications, almost a third of patients experienced a major complication with their treatment. 12% underwent a reoperation, and a 1% mortality rate in a series of 100 patients. Pretty grim statistics. Looking at our clusters of outcomes, 75% of patients with a poor clinical outcome also had a poor radiographic outcome, so there is some relationship, and 35% of patients with a poor radiographic outcome had a major complication. Almost 40% of patients with a poor clinical outcome also had a major complication. Looking at our final prediction model, some of these are intuitive, degree of deformity that you're starting off with, baseline neurologic deficit, osteoporosis, but there's others that were not at the time. So baseline pelvic tilt being elevated, the number of levels in the thoracic kyphosis, and whether or not that was included in the construct. These were novel concepts to us at the time and prompted us to look more globally when we're treating these deformities. This is not my case. This is a case included in the database, a 69-year-old male patient with a prior anterior fusion. Patient underwent a relatively simple operation, C2 to T4. We don't have the immediate post-op, but very shortly after surgery, this patient's outcomes had worsening T1 slope minus CL. Clinically, there was no improvement in JOA for MCID, DJK requiring reoperation. Risk factors here, the top two are obvious. The bottom ones, the initial treating surgeon didn't have full spine x-rays, and you could look at the pelvic tilt, and if you look at the thoracic kyphosis, clearly this was missed in the treatment of this deformity, which perhaps led to the reoperation. So conclusions from this initial kind of analysis of poor outcomes, about 20% of cervical deformity patients in our database had a particularly poor outcome collectively, not just unilaterally in terms of HRQLs or radiographically. Basically, this correlated with a lot of risk factors that we can quantify prior to surgery, which prompted further studies, as we'll talk about later in the day. And the drivers and the adjacent level segments in the thoracic spine are something we need to particularly look at when we're treating these deformities. So just to touch kind of Virginie's elegant talk on the biomechanics, not to belabor the point, but it's important to note that this is a very different biomechanics than the thoracolumbar spine. This is a very highly mobile and functional area of the body. It's compensating between two fixed segments, between the relatively fixed thoracic spine as well as the skull. And the overall goal here is not just to be highly functional in terms of rotation, but also to maintain horizontal gaze. Just as equally as it is important as a concept in adult thoracolumbar deformities, it's the overall cone of economy is very important with the treatment of cervical, and it needs to be taken into account when we realign these patients, especially in terms of flexibility of the cervical spine. If you look at kind of the progression of cervical kyphosis, and we're getting a little bit into the mechanical engineering here of the cervical spine, and I won't go over this too much, but basically, in a typical lordotic cervical spine, the axial forces are really applied along the instantaneous axis of rotation. As the lordosis is reduced, the axial force is now offset, and then ultimately we're getting a large moment arm where the greater the bending moment, there's further, this induces progression and begets further kyphosis amongst itself. And then we don't have time to talk about it today, but we've also quantified the amount of tension on the spinal cord, and this correlates very closely with the amount of cervical myelopathy symptoms and corticospinal symptoms, so that sometimes part of the myelopathy and the debilitating symptomatology of these patients is in essence related to their tension on the spinal cord. So realignment in these cases is really the treatment of those symptoms as opposed to just simple decompression of the neural elements. You're going to hear more about it in Dr. Protopsaltis' very nice talks on distal junctional kyphosis. He's done a lot of research on that. But I wanted to touch upon the research that we've done on that topic. Certainly, it's the most common presentation on, in terms of malcompensation after we spend a lot of time realigning these patients. And you saw this very egregious example previously. It's not often that that impressive, but we kind of initially started to define this based on our previous literature from PJK world, where we just randomly will choose either an overall value of 10 or a change in 10. And Themi and others have shown that this rate can be up to a third of patients that we realign. So what are some of the causes? So we've looked at kind of some limited predictive modeling given the sample size. And there's some things that constantly come out in the literature. So preoperative degree of deformity in the cervical spine, use of rigid biomechanics, so combined approaches, transitional rods with 5-5 at the transition zone, higher grade osteotomies, particularly close to the LIV. Those are some things that are particularly worrisome, and we need to take into account when we're minimizing our DJK rates, which you'll hear about in the next talk. So the other thing is we don't really know what DJK is. We know it's a kind of a global concept here. Is it normal compensation? Is it something where it's based on the degree of abnormality? Is it more symptom-based? So what we wanted to look at here was, a few years ago, was when does it become symptomatic, and what's the impact of symptomatic malcompensation on patients who just have simple changes at the junction, which may or may not be pathologic? So we broke down patients basically into the established definition, mild DJK, as well as patients that we considered symptomatic. So symptomatic was basically those who also had angular change, but on top of that had a necessitation for reoperation, and they had neurologic sequelae as a result of that, namely either spinal cord deficits, gait disturbances, hyperreflexia, spasticity that was new onset, that resolved initially following surgery and would resurface after the occurrence of the malalignment. And then we examined differences in outcomes based on these two kind of categories. Overall, 28% of patients developed this occurrence. In terms of timing, about a quarter of them were within 3 months, another additional 10% by 6 months. Most of these occurred within the first year mark, and an additional quarter by 2 years. Now, at the time, the database wasn't completely mature at 2 years, so take this with a grain of salt, but it's something you could kind of hang your hat on in terms of what we know so far about the timing and occurrence of DJK. By definition, about 40% had symptomatic DJK, about 62% had mild in our series. Of the symptomatic cohort, about 3/4 of them had one or more neurologic sequelae, so pretty much the predominance of them, the most common of which was new onset of gait disturbance in the lower extremities. Half of these required reoperation, and so looking at kind of this patient population more specifically, surprisingly, they didn't differ much in terms of their baseline myelopathy symptoms, myelopathy-related function, or overall quality of life, which certainly came to a surprise. So this is occurring after the surgical treatment. Looking at their outcomes, though, as a result of the occurrence of distal angular changes in the setting of neurologic changes, so we see that this had a tremendous impact on their overall outcomes. So they had, unilaterally, they had inferior neck disability indices, inferior myelopathy scores at final outcome, and inferior overall health states. And when we did a little bit more advanced statistics, doing conditional forward regression analysis, controlling for some of the other factors that could have contributed to these, we found that they're almost 4 times as likely as being 1 standard deviation below the mean collectively in all 3 of those metrics at the same time. So a very dramatic occurrence after we spent a lot of time and energy realigning these patients, and something we need to really work towards not having occur after our realignments. We then just did a quick sub-analysis looking at severe versus symptomatic. What about patients who just have severe radiographic and didn't have the occurrence of neurologic changes? And again, there's a clear difference in patients who have neurologic changes and those who don't, even regardless of the degree of angular changes. This is a nice example of a patient with greater than 20 degrees distal changes. The patient had a corresponding NDI score of 12 and an MGI score of 15 at 1 year, and was asymptomatic. So radiographically not great, clinically okay. So clearly there's disparities in our understanding of what this really occurrence means. So again, as a synopsis of this particular study, about 40% of patients with distal junctional kyphosis had at least 1 or more documented neurologic sequelae. This was clearly associated with an impact on their outcomes, and the angle is not necessarily the most important contributor here. Location, occurrence, and associated symptomatology is important. We then, just going to quickly run through this study, we wanted to look at, so what do we know about etiologies, right? So if it's a difference, so is there a difference in what causes these different types of malcompensation? Again, the same database was used here. And essentially, we use kind of game theory statistics or random forest analyses to look at difference in predictors of what are the causes of the occurrence of the alignment in terms of baseline and surgical patient factors. And I'm going to pick up the pace here. And basically, in terms of the breakdown, severe was 22%, progressive was 1/4, and symptomatic was 60%. Top risk factors, if you look at these are in order of importance. Top 3 are surgical. So top 3 are decisions that we make at the time of surgery. what type of procedure you're giving these patients, followed by a very robust contribution from radiographic contributors, and then rounding out the very obvious clinical risk factors that we talked about earlier. Looking at the risk factors for severe, 60% were radiographic. Factors for progressive, 80% were radiographic, 20% surgical, and symptomatic, 60% were clinical. So clear differences in the etiologies here. We also wanted to look at what was the impact of, so if you forget about the cervical spine, if you assume we're gonna get that correction right, what happens if, for the age-adjusted alignment goals that we know are well established in the thoracolumbar world, in terms of the thoracic spine and the kyphosis and the lumbopelvic mismatch. So looking at our cohort kind of overall, so there were no differences in the overall rate of distal kyphosis and undercorrected, overcorrected, and matching age-adjusted lumbopelvic targets. We think this is a little bit a result of the low numbers and lack of power in this analysis. But if you look a little bit more closely, there was a relationship that was decipherable. So for DJK patients, offset from age-specific alignment correlated with the magnitude and the presence of severe occurrence. And this was significant in both. It was also correlated with the more anterior to gravity line distal construct inclination. So clearly there's something going on in terms of the distal construct. And this is a case example of a patient with a severe, their risk factors mostly being patient-related frailty and osteoporosis. This is a progressive one, mostly being not recognizing the global sagittal deformity and the changes in the thoracic spine. And this is a symptomatic one, mostly here, let me go back to there. Mostly related to the risk factors of the patient. So the last few slides I wanted to touch upon was, the other thing we have to consider is that there's drivers of these deformities. So we may be thinking we're treating a cervical deformity, but if there's a contribution to a patient having hypo or hyperkyphotic thoracic alignment, then essentially, that's something we need to recognize in terms of our end level. So we need to be conscious of that and probably include that in our construct. So this was a theory that we had that we wanted to prove, and we looked at patients broken down into cervical primary drivers, thoracic primary drivers, defined as either less than 20 or greater than 60 degrees in their thoracic spine. And in terms of the cohort, we found that almost everyone who has a cervical primary driver had an LIV below their apex. But if you look at the thoracic primary or secondary drivers, 90% of these patients ended above their apex. So that's something that in many, at least conceptually, could be a setup for failure when we're talking about these types of problems. And in a nutshell, our study really showed that if you end your construct above your primary or secondary thoracic driver, they have worse overall outcomes pretty clearly. So overall, you may want to pace your LIV below the thoracic kyphosis apex in patients who fall under this category. I'll stop there. I'd like to thank the research team and the ISSG for inviting me to talk. Thank you.